Bismillahirrahmanirrahim. Today we're going to talk about an interesting topic, which is cardiac MRI, and the title of this talk is What Cardiologists Need to Know About Cardiac MRI. So, the first question uh, come to us today is what is an ideal cardiac imaging modality? What are the characteristics of an ideal cardiac imaging modality? Uh, an ideal cardiac imaging modality would have very importantly, a high spatial and temporal resolution. Secondly, it should detect myocardial edema and myocardial fibrosis with high accuracy and show this fibrosis whether it's transmural. Transmural making means that it's affecting the whole thickness of the myocardium, or subendocardial that is just affecting one layer, or subepicardial, so can detect the location of this fibrosis or scar. Um, it would be better if it is radiation free, not like angiography, which we use X-ray, cine, so there's a radiation. Also, if it's a gold standard or a very accurate tool in assessment of LV and RV function, and best of all, if it's operator independent. We know that echocardiography is operator dependent. So if we would have an imaging modality that is independent of the operator, that would be excellent. Also, an imaging modality with through 3D imaging. Uh, you can image in any plane that you want, and again, independent of geometric assumption. Geometric assumption, we use it in calculation of left ventricular ejection fraction in echocardiography. Um, Also, it would be better if you cannot report or write this word in your report, bad acoustic window. So if you have an imaging modality that is independent of acoustic window, that would be great. An imaging modality with unlimited field of view, and finally, part of a one-stop shop. What I mean by part of one-stop shop is you can do function, viability, perfusion, look at the anatomy. So if we just change the title of this light-to-cardiac MRI, these are actually the advantages of CMR. So CMR is not just a one-click technique. It's not like CT, you put the patient there and just click, and that's it in a few seconds. No, uh, it's more complicated, but it's very, very, very beneficial in cardiology. However, there should be clear communication between the ordering physician and the imaging staff that are performing the CMR. And also, the cardiologist should know what is the indication, what is the reason I would ask someone to do the CMR examination. So he can plan the adequate pulse sequences in the imaging planes that is obtained. And finally, most importantly, is to answer the desired clinical question. So could be the desired clinic question should be, please, I want to know what is the viability. Is this myocardial viable or no before I do PCI or cabbage? What is this mass suggestive of? Is it like benign mass, thrombus, it is malignant? So there should be a clinical question that you are sending this patient. So let's answer here this important question. Why CMR is an attractive technique? Actually, this is an image of um, the MRI machine. Um, Before I answer this question, I just want to explain that MRI is just an image of water. And since our body is full of water, about 70 to 80% of our body is water. But we're not just imaging the water, we image the hydrogen in the water, H2O. And again, we're not just imaging the hydrogen, we image the proton inside the hydrogen atom. I'm not going to talk about physics, but this is an example of the proton into the hydrogen atom, and it's always spinning, it's always moving. And based on some physics concepts, um, we can get image actually based on the movement of this proton. And this is the basics of what we call tissue characterization. Of course, you hear about tissue characterization in MRI. This is an example of tissue characterization. T1 and T2, these are characters inherited in each tissue. So liquid is different from collagen, from myxoid tissue, myxoma, from fat, from calcium, from fibrosis. Each tissue has different behavior under CMR machine. And also, we have in MRI what is called pulse sequences. Pulse sequences, these are some sequences that is developed by physicists, and we can use different pulse sequence to image the heart, so we get different information from the MRI examination. For example, we have something called spin echo, gradient echo, steady state free precision, fat suppression, we have tagging, we have phase encoding, um, we have delayed hyperenhancement, which is very important, and we're going to talk about it. This is an example of different pulse sequence of the same short axis of the heart, and you can appreciate how it is different using different pulse sequences. For example, if you have a cardiac mass, this is the table that you refer to after you do the cardiac MRI. So if you have lipoma, fibroma, myxoma, or thrombus, they will behave differently in MRI, and that will give you the basis of tissue characterization. Again, MRI do cardiac tissue characterization, but not histopathology. So this is the first reason why MRI is attractive, because it has the pulse sequence. The second thing is the cardiac MRI. You can look at the heart in different views, in any view actually you want. Two chamber, four chamber, three chamber, short axis. In three chamber you see the left ventricle, left atrium, aorta. In two chamber you see left ventricle, left atrium. So whatever you want, you can get the image that you want, and you can even create your own valvular planimetry image from just planning the views. The third reason, and I think it's one of the most important why MRI or cardiac MRI is important, is the viability of using the DHE or delayed hyperenhancement. And this is a slide from a paper, that famous paper in 2004, that showed that CMR was superior with respect to nuclear studies in detection of subendocardial small scars in dogs. So this is a heart of a dog that was harvested after the experiment, and you can see that MRI is just compatible with the pathology exactly, and the nuclear cannot show any scar or fibrosis. It's important in cardiac MRI to differentiate between what is called subendocardial scar or fibrosis and transmural. So this is a transmural, taking the whole thickness, and this is subendocardial, where you see still some myocardium. And this is important actually because in subendocardial scar, you see that these patients will benefit from revascularization. If the patient has transmural, there is no hope for this patient, and this cannot be provided except by cardiac MRI. Also, MRI can differentiate between acute event and chronic event. So if you look at this patient, he has a fibrosis. These both patient has scar and fibrosis, but this is chronic because in another sequence called T2 weighted image, this is an increased signal in T2 weighted image, and there is no increased signal in T2 weighted image. So we know that this is an acute event and this is a chronic event. Um, Moreover, the pattern of the scar or the fibrosis can give us an idea of what we are dealing with. So it gives us the hint if this is an ischemia or a non-ischemia. In ischemic cardiomyopathy, for example, we know that there's subendocardial, or transmural. We don't have any other pattern. In non-ischemic, based on the pattern, we can tell whether this patient has myocarditis or dilated cardiomyopathy, like here, mid-wall enhancement. In hypertrophic cardiomyopathy, we see at the insertion point of the RV into the septum, we see this classic picture. In sarcoidosis and Fabry disease, we see in the basal infralateral wall, there's subepicardial and mid-myocardial fibrosis. And sarcoidosis also, there's a predilection for the septum. Um, and in patients with amyloidosis, we see that there's a global subendocardial enhancement. And finally, the four reason of the why MRI CMR is effective. It's one-stop shop. One-stop shop. You can look at anatomy, volumes and mass, contractility, tissue perfusion, viability, edema, inflammation, fibrosis, metabolism, and moreover, you can look at the coronaries. So this is an MRI 1.5 Tesla, and this is the new machine that we use nowadays. It's a digital broadband broadband system. Uh, it's very fast and with high signal to noise ratio and gives high resolution. The only problem with this machine that we have 5% of the population who are claustrophobic, but this new machine has actually a 70 centimeter bore, which is really wide. It's wider than previous old scanners. So, so what is important in this topic, or what the cardiologists need actually, is not cardiac MRI. They need to know first when a cardiologist should order a CMR study while he is in his hospital or he is in his clinic. There is appropriateness criteria of multi-society that we can discuss some of it now based on case studies. So, first indication is assessment of ventricular and valvular function. For example, assessment of complex congenital heart disease like anomalous coronary arteries, great vessels, cardiac chamber, and valve. This is a classic indication, and we know for decades that MRI is important for congenital heart disease. Also, it's the gold standard for assessment of LV function, especially when you have discordant information from prior tests. So you have like three echoes, and each echo say one say 50% ejection fraction, one say 30, one say 20. So sometimes this is the situation, and you have to go to MRI since it's the gold standard for LV function and RV function assessment, or evaluation of LV function when the patient has technically limited images from echocardiogram. Let's discuss this case. This is a case of 76-year-old man presented with progressive shortness of breath. Um, he actually had previous coronary angiography, and he has multi-vessel disease, and he refused to do cabbage at time of his coronary angiography. Years later, he deteriorated, and he agrees to do the cabbage, but the surgeon has actually four reports of echocardiography. One show the ejection fraction is 35, and the last show 20%. So he really doesn't know which one is correct, and he needs to know what is the viability. Shall he go with this with cabbage or not? So as you see here, this is a two-chamber view. This is the left ventricle, this is the left atrium, and this is the mitral valve. And you can appreciate the mitral regurgitation here. So if you look at the contractility, what do you think by eyeballing is the ejection fraction? Um, I don't believe it's more than 20%. I think you agree with that. This is a four-chamber view: left ventricle, left atrium, right atrium. Now you have three-chamber view, and again the ejection fraction is less than 20%. Why CMR is the gold standard because in short axis view, we get a stack of the short axis and we measure the volume using the modified Simpson rule or the summation disk. And through all of these measurements, we get the ejection fraction. So it's different from echocardiography. That's why it's highly accurate. This is again a short axis. We start from the apex and then we start imaging till the base of the heart. All of these are traced by the software of the CMR, and you can get actually the volumes in diastolic and systolic volume, stroke volume, ejection fraction, and even the ventricular mass. Again, this is the same patient, and you agree that it's at most is 20%, but actually it was calculated to be 17% by cardiac MRI. This is the viability or delay hyperenhancement. As you see here, there's a mid-wall enhancement. That means the patient now is in developed the final stage of ischemia, dilated cardiomyopathy. And look at the thickness of the myocardium. It's less than 5 millimeters. So this patient is actually has burnt myocardium. So do you think cabbage will help him now? 17% dilated cardiomyopathy, end stage. So actually, the surgeon refused to do that. Cabbage, and he asked for an ICD and optimizing medical treatment. So another indication for CMR is evaluation of specific cardiomyopathy like infiltrative or HOCM uh, for cardiotoxic therapies using the delay hyperenhancement. This is a case of 22-year-old college student presented with pre-syncope. Her ECG show LVH, and of course, it was easily diagnosed by echocardiography. It's HOCM due to increased thickness. But the question here was, the patient has pre-syncope, and shall we put an ICD or no? As you appreciate here, the thickness here is about 28 millimeter, 28 of the septum, 28 millimeter. Again, this is another view, a three-chamber view, or we call it in echoparasternal long axis, left atrium, left ventricle, and aorta. And you see also the septum is 28 millimeter. So the most important here is look at the viability. And if you look at the short axis, there's a bunch of fibroses here, which represent myocardial. This array, all of the area, these area are myocardial fibroses. Again, this is short axis. You see the myocardial fibrosis. This is a four-chamber view. We see all of this myocardial fibrosis. So here was the amount of, we measured the amount of myocardial fibrosis, and it was like, this is a two-chamber view. Again, there's an anterior fibrosis here and here. And so the amount was more than 15%. It's important for a risk stratification. So we know that the patients with a high risk factor like family history of sudden cardiac death, syncope, multiple repetitive non-SVT, hypertension on exercise, massive LVH 30 millimeter or more, we would go for an ICD. And patient with low risk, we will not put an ICD. The problem is the patient with intermediate risk, where we have to think about it. So MRI would help us just to risk stratify these patients, whether we put an ICD or not. And since this patient has more than 15% amount of fibrosis, uh, her physician just actually in the United States they put an ICD for her. Um, Another indication is detection of myocardial scar and viability to determine the location and extent of myocardial necrosis, especially the no reflow area or region after myocardial infarction, to determine the viability prior to revascularization, um, to see if this patient will recover, his myocardium will recover after PCI or cabbage, or when you have an equivocal assessment by SPECT or the vitamin echo. But actually, nowadays, CMR is much high. accuracy than the vitamin echo and nuclear studies. This is an example of 35-year-old man. He has a recent anterior MRI, and his coronary angiography showed total proximal LAD, and this was missed anterior MRI, so it was not a primary PCI. And he was sent for CMR viability. And this is a two-chamber view, as you see. You can appreciate the LED, the anterior wall is akinetic, and his ejection fraction was about 30%. When we go to viability, look at the viability. This is his viability. This is a two-chamber view, and you can appreciate there is a transmural scar here. The whole anterior wall, from the base to the apex, is scarred. And in short axis, even the anteroseptal, here's the anterior and anteroseptal wall, is also has transmural scar. So what if someone just insisted, he doesn't think about the importance of viability, he believed about the open artery hypothesis, like, oh, I would increase the stability and the electricity of whatever. And he insisted to do a PCI for this patient. Here's another important finding by MRI that you see this uh, no signal or hypo-intense area with this scar, and this represents a microvascular obstruction. So a scar, and you see inside of this black thing, with this represents a uh, uh, microvascular obstruction (MVO). That is explained in the coronary angiography by the nightmare of no reflow phenomenon. Another indication is characterization of native and prosthetic cardiac valves, including the planimetry of stenotic disease and quantification of Richardson disease. This is an example of 68-year-old man with asymptomatic severe aortic anergia. He had serial echocardiography study shows that his ejection fraction is preserved 68%. This is a four-chamber view, so it looks good contractility, but we don't know if it's really 68 or not. And this is the aortic regurg here in three-chamber view. You can see the regurgitation here through the aortic valve. However, the measurements of MRI show that um, the endostolic pressure, endostolic volume is huge, is high, and the actually ejection fraction was like borderline. It's not like 68. It's really actually 53. And this would change actually the decision. While watchful waiting of his aortic regurgitation, the patient was operated immediately. Another example is about 49-year-old man with intermittent chest pain, lightheadedness, palpitation. He has white complex tachycardia. He received cardioversion. He did echo, which show bad acoustic window. He has different differential diagnoses: VT, RVOT, VT, ERVC, bundle branch reentry, idiopathic VT. So he was sent for MRI to look for his to see if there's a RVC or any scar in his RV or myocardium. And as you see here, there's a microaneurysm in the RV wall, these kinetic areas, and this is a fat saturation. There's a fat, you see black here. We saturated, so it's black now. Uh, Before it was, it's white or it was increased signal. And on delay enhancement, hyper enhancement, you see there's a fibrosis. So there's a fibrofatty infiltration into the RV. But most importantly is not the fibrofatty infiltration. We have what is called revised task force criteria for assessment of ARVC by CMR. And if we look carefully to the MRI characteristic of the RVC for diagnosis of the RVC, we should have one of these items, regional RV akinesia or dyskinesia or desynchronous RV contraction, and one of the following, which is increased diastolic volume or decreased ejection fraction to less than 40%. So ARVC it's a classic indication of ARVC. So if you suspect ARVC, send the patient to CMR. This is another example of a 47-year-old female. She complained of typical chest pain. She had ST elevation, cardiac enzymes are elevated. She was operated on by coronary angiography and has normal coronary angiography. And this is her MRI. As you see, there, this area of the apex and adjoining area are not moving. And this is the viability. There's no scar. So area of akinesia with no scar would suggest what is called apical ballooning or Takotsubo cardiomyopathy. If you image this patient after a while, like 3 to 4 weeks, you will see that the patient regained her function after medical treatment and markedly improved. So another indication of cardiac MRI in patients when you suspect stress cardiomyopathy or Takotsubo. Another classic indication of cardiac MRI is what you see here, the left ventricular non-compaction. It's very easily diagnosed by cardiac MRI. And most importantly is to look at the ratio between a non-compacted to compacted myocardium at end diastole, and it should be more than 2.3. So I think it's an easy diagnosis with cardiac MRI. Sometimes it's possible with echocardiography, but in cardiac MRI, due to high resolution, you can easily diagnose. Another case about 72-year-old man with nephrotic syndrome, peripheral edema, and increased shortness of breath on exercise. He showed moderate concentric LV hypertrophy and preserved contractility. These are the images. As you see, there's an LVH. This is a 5-chamber view. This is short axis. This is 2-chamber view. And this is tagging technique. Tagging technique, we put these tags, or you see these squares. Some of these are contracting and some of these are not contracting. That would tell you that this patient has some form of restrictive cardiomyopathy. And actually, through a computer software, we can measure these tags by the software and can give us detailed information about the diastolic function of the heart. But it's still the echocardiography, which is much better than um, MRI in measurements of diastolic function. And this is the delay hyper enhancement, where you see there's a diffuse hyper enhancement, diffuse subendocardial hyper enhancement. So, and we see this only in patients with amyloidosis. So the diagnosis of amyloidosis in this patient was established. So this is, if you suspect infiltrative heart disease, please send the patient to cardiac MRI. So any restrictive cardiomyopathy, you should send the patient, or LDH more than 15. I mean, not more. I mean, if you're suspecting hypertrophic cardiomyopathy, you would risk stratify. If you have LDH for another reason, you would likely to know what is the reason of his LDH, especially when it is unexplained. This is an interesting case of 45-year-old man, previously healthy. He started to have progressive shortness of 5 months ago, and his echocardiography, he has multiple frequent echocardiography with different operators. They all give him the diagnosis of apical hypertrophic cardiomyopathy. And lastly, one of the operator think about cardiac MRI to help. The patient was given beta blocker and he was not improved for 5 months. So that's why they send him for cardiac MRI. And as you see for the first while, this is looked like the two-chamber view and looks like it is um, really an apical hypertrophic cardiomyopathy. Again, it looks like apical hypertrophic cardiomyopathy. When we did the perfusion study, um, actually the cavity here looks different from the myocardial muscle. Again, here in different in T1 weighted image. So with a myocardial signal is different from what here in the cavity. So it's very suspicious. So when we inject the gadolinium, will give us the clue. This is a cine SSFP sequence, two-chamber view. It looks like apical hokum. This is a four-chamber view. Again, it looks like apical hokum. And this is the delay hyperenhancement. Actually, it was not apical hokum. This is diffuse subendocardial enhancement with a thrombus inside that is not taking the gadolinium. And that means the diagnosis is endomyocardial fibrosis. So the treatment was shifted from beta blockers to corticosteroids, and the patient started to improve. So here's a clear example how cardiac MRI saved the life of a patient. If you just continue to echo without thinking about other differential diagnoses, the patient would not benefit from treatment. Another indication of detection of coronary artery disease when you have intermediate pretest probability of coronary artery disease, like ECG uninterpretable or unable to exercise, or the patient has stenosis that is of unclear significance on coronary angiography. This is an example of myocardial perfusion CMR in 65-year-old female to evaluate exertional chest pain. This is the stress perfusion, this is the rest perfusion, and this is the viability. If you look at the viability here, if you look at the viability here, there's no scar. And if you look at the stress perfusion, there is a hypoperfusion defect, while at the rest there is no hypoperfusion defect, and that would say that there is this area is ischemic. And this is the coronary angiography of this patient, where she has critical LED at mid-LED lesion. Also, evaluation of cardiac masses is a common indication of cardiac MRI. Like, like here in the myxoma, you see here, there's a heterogeneous uptake of the mass here. So the gadolinium, by the gadolinium, and we give the diagnosis of myxoma. So it's very important actually to look at masses by cardiac MRI. This is an example of a mass in the pericardium which is high in T2 signal that is a pericardial cyst. So again, this is the table that we showed previously, and we can differentiate between um, different cardiac masses. Also, MRI is important in evaluation of myocarditis, especially in the era of COVID-19, because post-COVID myocarditis is very common nowadays, and you should have high clinical suspicion about myocarditis. And this is an example of patient with COVID, and he has high T2 weighted images. You see here in the inferior wall, and this is the fibrosis at the inferior wall, and this is a patient with uh, clear diagnosis of myocarditis. Again, this is the you see here the fibrosis is subepicardial, so the patient is has a diagnosis of myocarditis. Also, we can evaluate pericardial conditions like constrictive pericarditis, as you see here. There's thickened pericardium, ventricular interdependence, septal bounce. All of these features can help you in making the diagnosis of constrictive pericarditis. Also, evaluation of aorta and aortic dissection. MRI is um, beneficial, like other modalities, CT and TEE, in visualizing aortic dissection. Also, to evaluate pulmonary veins prior to atrial fibrillation ablation can give us a good example using the whole heart axial images, where we can see the pulmonary veins very clear by cardiac MRI. We don't use any radiation. We don't use even contrast. We don't need here to inject the contrast. We can see the pulmonary vein without injecting any contrast. Here's the pulmonary vein. Here's the right. And here's the left. Very easily can be seen. But also, we can look at the coronaries. If you look here again, it's easy to look at the coronaries. You can see some of these coronaries on cardiac MRI can give us a clue on the anomalies. And if the patient has heart rate is adequate, we can look at the patency of proximal and mid segments of coronaries. So this is an image of coronary MRA by at 1.5 Tesla. As you see, you can look at the LED, RCA, LCX. Of course, not all the cases would be excellent like this, but MRI is an important tool when you have no other clues. So if the patient has like um, high creatinine, renal impairment, and you cannot do angio or CT, CMR is an alternative. This is also MRI is insensitive to calcification. This is a CT, where you see the blooming artifact of the calcium. But here you can see through the calcium, you can assess there is a critical stenosis of the vessel. Finally, MRI will allow what's called a flow analysis. You can image or can assess the flow in the aorta by phase contrast, phase encoding, and we can get this number and this curve, and you can measure accurately the flow in the ascending, descending, pulmonary, and other vessels you want to assess. So my take-home message, you should know actually when a cardiologist should order the CMR study. You should know what are the specific indications when to send patient for cardiac MRI, and this is very important nowadays. And also remember that cardiac MRI is cost effective. Cost effective means even if the price of CMR is maybe higher than echo, but it's equivalent or maybe less than CT, but it will give you the amount of information that you get from from MRI will help you actually to assess the patient correctly. Thank you so much. This is my email if you need any further assistance. Thank you.